So it's my pleasure to introduce our first speaker, Sina Pourtaheri. He's a surgeon in the New Orleans area and will speak to us about the nuances in management of spinal osteomyelitis with an evidence-based approach.
Thank you, everyone. Thank you, Lionel, Kyle, and Lee Tan for putting this together. It's always a pleasure to be out here in Hawaii. Great atmosphere. So my talk's going to be about osteomyelitis and epidural abscess and treatment options for it. So I have no relevant disclosures for this talk. So in terms of the outline, we'll start with the incidence and demographics. We've noticed that osteomyelitis of the vertebrae has increased as time has gone on. We'll go over factors towards that. We'll go over utility of cultures in terms of blood cultures, urine cultures, and when do you have to do a biopsy? Do you have to do a biopsy if you have positive cultures? We'll go over the Cherney classification of osteomyelitis, which is based for long bones, and then kind of look at modifications for that to be more pertinent to vertebral osteomyelitis. And then we'll talk about instrumentation when you have osteomyelitis. Can you put instrumentation in? Is it safe when you have infection to put hardware? And then next, in terms of biologics, when you're fusing for osteomyelitis, which biologics should you consider or prefer? Epidural abscesses, do you have to surgically treat them, or can you non-operatively treat them with antibiotics? And then antibiotic penetration, intravenous or oral, to the bone or disc. How well does the antibiotic penetrate bone and disc in terms of medical management? And then I'll go over my treatment options for cervical and thoracolumbar osteomyelitis, particularly surgical treatment options. So this is one of our papers going over the epidemiology of vertebral osteomyelitis. As you can see from the diagram that over time it has increased. And the main reason for that is that the immunocompromised population, particularly organ transplantation and diabetes, has increased. In terms of the pathogen, most common is Staphylococcus, a little bit more MSSA versus MRSA. This is a good diagram from the paper showing that a large percentage of patients have diabetes, about 13% here, or immunocompromised states, about 10%. And the most common reasons for it is not direct communication of an infection, like you had a spine surgery and then that area got infected. It's usually from a remote location, you have an infection and then you get hematogenous spread that goes to the vertebrae that's infected. So in terms of the increased rates, mainly related to diabetes and organ transplantation, most common reason for vertebral osteomyelitis is hematogenous spread, not direct communication. This is one of our other papers, specifically looking at delay in diagnosis. There's a high rate of delay in diagnosis in vertebral osteomyelitis for a variety of reasons. A lot of times it's non-specific back pain, which could be multiple different sources for non-specific back pain when they present to an emergency room and or clinic. But the good parts of looking at delay in diagnosis cases, we were able to find out some interesting things. In terms of blood culture, if you take a blood culture within 1 month of the infection, it's more likely going to be positive and be able to identify the pathogen that is causing the infection, versus if it's over a month, it's less likely to be positive. So getting blood cultures and urine cultures early on is favorable for the prognosis to determine the pathogen. Also, in terms of biopsy, if you take a biopsy within 2.5 months of the infection, it's more likely to be positive. If you take a biopsy in a delayed fashion, more than 2.5 months from the time of infection, the biopsy is more likely to be negative, and you won't be able to determine the pathogen that's causing infection. Another interesting theory is that a lot of these patients do present to an emergency room for non-specific reasons, and there's a high rate of these patients that come to the ER that they had trauma or some form of trauma. So there's some theories that when you have trauma to the spine, you're affecting the vascularity to that area, and then you get a bacteremia and hematogenous spread to that area that there was trauma. But again, that's a theoretical concept, but there is a high rate of patients having trauma initially and then developing vertebral osteomyelitis. So you'll see throughout the slide, there's this thing called IDSA. It's a society called Infectious Disease Society of America. It's predominantly infectious disease doctors, but there's also a spine surgeon in the panel. And they make recommendations, a lot of recommendations based off their review of RCTs on vertebral osteomyelitis and osteomyelitis in general. One of the biggest strong recommendations is based off of blood cultures. When the blood culture is positive, that's most likely the pathogen that's causing infection. So if you have a positive blood culture, you do not and you should not take a biopsy because that's more likely the pathogen. So doing a biopsy is not increasing your improvement and you're just increasing risk. So if you have a positive blood culture, that should identify the pathogen. And this is every one of the RCTs concluded with that same concept. The blood culture is more likely the pathogen, so you don't have to take a biopsy. Empiric antibiotics, in general, you want to avoid it. You only do it when you're required to do it, and there's different reasons for that. So the only time you'll do it is when you have neurologic compromise, you have a patient that has a progressive neurologic ailment, or when you have sepsis causing hemodynamic instability. In general, you will do, if your blood culture is negative, your urine culture is negative, then you get a biopsy. You don't want to do antibiotics before that because if you can't identify the pathogen, it will affect the prognosis of the osteomyelitis in terms of getting a cure versus just becoming a chronic osteo case that's refractory to surgical and or medical treatment. So you don't want to convert a pyrogenic osteomyelitis into a chronic osteo with non-union of the osteo. Only time you ever repeat a biopsy in osteomyelitis if it grew out a skin contaminant. If your biopsy is negative, then you should look for pathogens that are hard to grow out, like fungal infections, mycobacterium, and brucella. And if your culture is negative, consider getting a bacterial nucleic acid amplification to identify the pathogen. So if you repeat the biopsy, if it was negative, it's unlikely to identify the pathogen. So doing an open discectomy or open biopsy or percutaneous, you're not going to get a different result, so it's probably not worth the risk. This is a Cherney classification. Again, it's based off of long bone. Really don't have a model for vertebral osteomyelitis. And the Cherney classification is taking two things into account: the anatomy in terms of location of infection, and then the host. So anatomy and host. Anatomy, if you go down the stages, is in the medullary canal. Again, medullary canal is important because it has good vascularity. You'll have good penetration of antibiotics in that location versus if it's cortical. And then in terms of host, do you have a strong host or do you have an immunocompromised host? Your host makes a big factor in terms of the treatment. If you have a poor host, it's more difficult to medically and or surgically treat the patient and eradicate the infection. So I think in terms of the Cherney classification, we should have one that's kind of geared towards specifically vertebral osteomyelitis. So Cherney is for long bones, but so I think for vertebral osteomyelitis, we should have a different classification scheme, similar to like a S-lick score or T-lick score for thoracic or cervical trauma, where you have categories and then determining when you should do surgery. In terms of the categories identify that should be considered as host, again, do you have a medically resilient host? Is it a healthy patient that could eventually get cured of this infection? The vascularity in terms of the location of infection, and also the patient. Again, do they have atherosclerotic disease, kidney disease? Are they going to get good penetration to of the infection with antibiotics? Because that will play a role. If you have a poor host, then more likely you might have to consider surgery because antibiotics probably won't work well. The pathogen, you want to know the virulence and susceptibility. If the pathogen's more virulent and not as susceptible, consider surgery over just medical treatment. Location, again, infection, is it in an area of vascularity? Is it also around neural elements? Location makes a difference in terms of treatment options. Size makes a big difference, particularly with epidural fluid collections. If you have a larger size epidural fluid collection, it's more likely to be an abscess versus a phlegmon. Abscess meaning the antibiotic will not penetrate the core of that infection, and more likely you would have to remove it by surgery. Neurologic status is important, and then also is it spinal cord or cauda equina. in terms of the compression. Stability, do you have anterior column support or don't have anterior column support? That's also an important factor. And acute versus chronic. So this is one of our papers looking at 104 cases treated surgically, kind of looking at instrumentation, is it safe? So these cases that we use instrumentation preoperatively, they're more likely had instability or neurologic compromise, and they had a larger burden of infection in terms of MRI and CT scan of how much area of infection is. So these are worse infections. However, the clearance of the infection and their mortality in ODIs were identical to the patients that didn't require instrumentation. So instrumentation is stable, is safe to do, and you should consider it when you have instability. In terms of instrumentation, titanium, it has a smoother nanostructure, so you're going to get a thicker surface oxide layer, so you'll less likely develop a biofilm from bacteria. And then if you have gross pus in the area, then consider not putting instrumentation and going back. But even if you have gross pus in the area where you're doing the surgery, you can consider instrumentation. We showed in that paper you can, and then you can consider doing hardware exchange at next surgeries, like 2 days later or a week later. In terms of instrumentation, interbodies and corpectomies are safe. And previously, we used to use more structural allograft or structural autograft. We move more towards metal and PEEK. A lot of times we would say metal is better than PEEK because of biofilm, but then there's no actual clinical study showing one better than the other, but my preference would be metal because we talked about the oxidized layer in biofilm. In terms of instrumentation, if you in terms of acute versus chronic, if you have an acute case, it really is, it's almost like cancer or metastatic cancer. If we're moving more towards just stabilize and then getting the infection off the neural elements and then treating with the antibiotics. So in acute cases, either do complete resection or partial resection depending on the scenario. In chronic cases where there's still residual infection, meaning infections, there's still pus in the bone or soft tissues, those are cases where you want to do a complete resection, get all of it out. Versus chronic cases where it's more of like a burnt out infection. There's still, you see phlegmatitis in the bone or adjacent areas, and you get this kind of like non-union that you see through the erosive changes. Those cases, it's more, you could just do a partial resection and get stability. So you just need the bone to heal. So you need stability and then more likely a cage to bridge the area where the bone is kind of burnt out and still has a non-union. In terms of anecdotally treating with these burnt out infections with non-union, I recommend there's like a technique where you kind of telescope the cage past the area of infection. So you don't have to get the cage perfect, get it past that. You can get it telescoped through the end plates and kind of bridge the area where the infection or burnt out infection is. It's more phlegmatic disease. It's not really like gross pus, so you don't have to worry about that bacteria sticking onto the metal cage and then creating a new problem. In terms of biologics, BMP I think is a great option. It's osteolytic, so it'll help with eradicating infection, but also you have to have strong stability because of that osteolysis in the first 1 to 4 weeks. So get rigid fixation, but it's good for infections because of osteolysis, and it's very inflammatory. So a lot of studies have looked at open tibia fractures and using BMP. So that's why I think BMP is a great option in vertebral osteomyelitis. DBMs are safe. There's concern with ceramics because they have a high surface area, so you can increase biofilm formation and bacterial aggregation. So a little bit of concerns with that. In terms of biologics, again, a lot of these cases, it's about getting the bone to heal. So you want to go aggressive with stability and biologics to get that to happen. If it doesn't heal, then you'll have to do secondary surgery, or it's more difficult to treat. Antibiotic beads have become popular. Again, talking more about biodegradable antibiotic beads. They work great in terms of osteoconductive, and they provide high level of antibiotics in the area, but they have a high wound complication rate in terms of seroma formation. It's very inflammatory, which treats infection, but however creates a new problem with seroma. This is a paper, 32 patients treated with antibiotic beads. They basically did instead of using a metal cage, they just put antibiotic beads where they resected the bone. And they showed out of these 32 patients, no recurrence infection. I reviewed the paper myself. Again, a lot of the CT scans, I don't think it was eradicated. And two, if you're going to do an anterior-based surgery, either less invasive open thoracolumbar approach, and you're going to put somebody through the risk of that approach, I think it would make more sense to put a cage versus just putting beads in that area. Because if you're going to put them through that, go for your best option. Don't just probably just don't put beads. But this is a paper that showed no residual infection. In terms of the beads, calcium sulfate versus hydroxyapatite antibiotic beads. My preference, if you're going to use them, I think it's great in posterior lateral gutters when you're doing open fusion. I recommend using a small kit. Don't use the large kit, so the smaller beads, and don't use all of it, because if you use all of it or use the larger beads, you will get a seroma, and then you'll have to do repeat surgery and things like that. And then also put drains, subfascial and superfascial, to kind of prevent that complication, and leave the drains in a little bit longer. And the reason why I recommend in posterior lateral, it's great because you're not going to have compression of neural elements related. Posterior lateral is difficult to heal because of muscle creep and getting the wound to heal with the open posterior lateral fusion. So I think that's a great area to do it. And then BMP, I think, is a great option in the posterior lateral. And my preference in terms of if you're putting a cage is use BMP, maybe another biologic. But BMP is great just because we talked about osteolysis. It's also pro-inflammatory in terms of treating the infection. This is another one of our papers looking at epidural abscess. So we define them as epidural collection, and then either we define epidural collection as abscess versus phlegmatus. And that's defined if on contrast study, does the contrast go all the way to the core. So in these larger collections, which are more likely to be abscess, you more likely want to do surgery. The cases where you didn't do surgery with these larger collections, where it's an epidural abscess, less likely to eradicate the infection, and you'll more likely have failure of medical management. So if it's truly an abscess, large size, we define in our paper large by looking at ones that resolve versus didn't resolve 1 cc on MRI, 1 centimeter versus 1 centimeter on sagittal and axial cuts. Smaller collections, so most likely phlegmatic disease, do very well with medical management. You probably don't have to do surgery if there's not neurologic compromise. And then the cases where you get enhancement, you do a contrast imaging and you see it enhancing, those do very well with non-medical management. The antibiotics will penetrate the area, because if the contrast goes to the area, then the antibiotics will go to that area that you have the epidural fluid collection. So enhancement is key. And size makes a difference because it's larger, less likely it's going to enhance through and through the epidural abscess versus phlegmon. This is another study looking at epidural abscesses, 128 cases, high failure rate, 41 cases of 41% failure rate in medical treatment for epidural abscess. Big factors goes back to kind of churning, classification, host, and pathogen. If you have diabetes, poor host, less likely to heal this, and also if this is a very virulent pathogen, it's better to do surgical treatment. Non-operative or medical treatment might not be successful. This is another one of our papers looking at polymicrobial versus monomicrobial vertebral osteomyelitis. Polymicrobial, these are more difficult cases, higher mortality rate, lower clearance rate of infection, larger area of infection, more likely instability. Again, going back to the classification scheme I was going over, host, pathogen, stability are crucial. So if you have a poor host, highly virulent bug, and don't have stability, that's really going to affect your prognosis. Efficacy of antibiotics for vertebral osteomyelitis, epidural abscess, and discitis. So the antibiotics that you give intravenous or orally, how much is that actually penetrating bone? It really depends on the antibiotic. So quinolones, macrolides, linezolid have good penetration of bone. You get a high bones concentration in relation to your serum concentration of the antibiotic. However, if you look at cephalosporins or glycopeptides, they don't have good penetration of the bone. You get low percentage that actually goes to the bone compared to these macrolides and linezolid. And then cortical bone has bad penetration in terms of antibiotic penetration of bone versus cancellous bone, which is very vascular. going back over that, quinolones, macrolides, linezolid do have good penetration. Beta-lactam antibiotics do not have good penetration of the bone. What about the disc? Antibiotic penetration of the disc. How does that work? This is a landmark paper out of JBJS 1987, and it was for AIS where they're having anterior fusions. They sent the disc for analysis. Of all the 25 discs of 12 patients, there was not one bit of antibiotic detected on bioassay. However, this other paper kind of does not have the same findings. This was a case where they're using the same prophylactic dosing of antibiotics you normally would, and they're doing a microdiscectomy. So they're getting prophylactic dosing for elective microdiscectomy. They showed the positively charged antibiotics like clindamycin were more likely to show tissue dosing of the disc with the antibiotic versus the negatively charged like ceftriaxone and vancomycin didn't. So similar to what we saw before, the antibiotics that penetrate the bone well also penetrate the disc well. The ones that don't penetrate the bone are not going to penetrate the disc. And they said positively charged. I don't think that's a reason behind it. That's actually paradoxical, because if it's positive, then there's multiple different reasons why, from a material science point of view, that wouldn't work well. In terms of stability, surgical treatment and stability for osteomyelitis, my preference is percutaneous instrumentation 1 or 2 levels above the level of infection. Don't instrument the infected level, and do it percutaneous. And then do sequential blood work and imaging. I think the 6 weeks and 3 marks are very crucial in terms of what the blood work says, in terms of ESR and CRP, and then MRI and CAT scan. So see if it's responding in terms of blood work and imaging. If it's responding, the infection looks like it's going down, then you can just watch and don't have to do a corpectomy or interbody fusion in the area where you have the osteomyelitis. If it's not responding, jump to a corpectomy or interbody. In terms of 6 weeks versus 3 months, I think the main crucial point to look at this is that do you think with your current management in 3 more months is this infection going to go away? So based off the trends of the blood work and the imaging, do you think this will be eradicated? Because when you're having the antibiotics, it's protecting your hardware. In terms of having the instrumentation, your hardware is getting protected, and then you can't give antibiotics for infinite time. There's a finite time that you can give it. So you want to its time is crucial in terms of in these gray areas. Do you do a corpectomy or interbody? In these gray areas where it's not absolute, do you do surgery versus continued non-operative treatment? If it's not responding well, I think you should jump and convert to a corpectomy or interbody fusion. I'll kind of skip over this. This is that one society. Again, a lot of with this society is that most of the people on this panel are all infectious disease. There's only one spine surgeon on the panel. And then in terms of when they analyze these papers, they didn't really categorize the osteomyelitis. Is it stable, not stable? Is it of the posterior elements? There's not really a surgical critique of it. It just, they have osteomyelitis and then what the pathogen is in terms of gram-positive, gram-negative. So that's where you see some of the issues with the. And then also the way they would manage it before, a lot of these surgery were open thoracolumbar approach versus less invasive thoracolumbar approach, and we have percutaneous instrumentation. It's kind of analogous to Wood's paper on burst fractures, where he showed no difference between surgery versus a non-operative treatment. When in that paper with Wood, again, it goes hooks and rods, 4 levels above, 2 levels below. Now we're doing percutaneous instrumentation, so it's not apples and it's more apples and oranges when we're comparing the way that we're treating surgically osteomyelitis. And then the pendulum has swung. Antibiotics really haven't improved in terms of targeted antibiotics. The surgeries have improved in terms of the approach and the mechanics of the implants. And then again, with the society in terms of treatment, in terms of antibiotics, how long do you treat or don't treat? It's kind of similar to VTEs or anticoagulation in spine surgery for elective surgery. Again, chest guidelines are always very aggressive with anticoagulation. When you come to NAS or especially society meetings, the guidelines are not as aggressive with anticoagulation. So it really is the spine surgery versus infectious disease. We're trying to avoid further surgery and catastrophic failure. Infectious disease is trying to prevent resistance antibiotic resistance in the community, and antibiotic side effects. Again, in terms of antibiotics, osteomyelitis of the vertebral osteomyelitis is the most difficult to treat compared to long bones, and there's a high failure rate when you do a short-term antibiotic treatment based off this paper versus a longer duration antibiotics. In terms of antibiotics, we're kind of saying the technology has improved a lot, surgery has improved a lot, so you can see the pendulum has swung in terms of treatment for osteomyelitis. We're moving more towards surgery. Once targeted antibiotics improves, you'll see that pendulum switch back to more towards antibiotics. It's just like cancer, metastatic cancer treatment. We move more away from radical resection, more just percutaneous instrumentation with radiation. Same thing goes with antibiotics. If antibiotics improve, you'll see the pendulum swing more towards less aggressive surgery, more about antibiotics. In terms of my opinions, characterize the osteomyelitis and discitis in terms of stability, host. We kind of went over that classification. And then trends, both blood work and imaging at 6 weeks and sequential are very key in terms of where you go treating this. In terms of the antibiotics, it's bioavailability and suppressibility. Again, bone, cortical bone doesn't penetrate well, disc doesn't penetrate well, and then suppressibility. In terms of antibiotic, is this antibiotic very effective for this specific pathogen based off this your cultures? And in terms of some opinions on cervical, if it's, again, if it's of the facet joints, generally in these cases, it doesn't involve the anterior column, so you can just treat it medically or just do a surgery in terms of debridement of that facet. These are 2 case examples. 58-year-old female, she presented initially with headache, and then later on evolved to back pain. If you look at the image, you can see that infection is just of the posterior elements, and the patient has this epidural abscess. There's a little bit of lysis through the facet joints, erosive changes with gapping of the facet joints. So just epidural abscess with just posterior involvement, no anterior column involvement. We did a laminectomy, and you can see that 6 weeks and 3 months later was very favorable. The lab results all went to normal, didn't require further surgery. Different patient, 62-year-old female, but back pain, radiculopathy, has osteomyelitis discitis at T12L1, erosive changes, has dish. Decided to do instrumentation 2 levels above and below percutaneously, no instrumentation infected level. And these are their images. You can see the labs, next slide, that it never went completely to normal. This is kind of at the point where it didn't go completely normal. So decided to do an interbody at T12L1. And if you look at the new labs, they went completely normal. CRP went below 10. Thank you.